say that essential, again, using the word in this context, as you review, this is ultimately about patients receiving care as you look at essential health benefits. And that we want to make sure that whatever this is talked about in terms of addressing and enhancing the benefit, or whether we enhance the benefit or not enhance the benefit, that ultimately at the end of the day, those services get covered. So we think the gaps and the issues that are associated with people getting that coverage is essential to what you're looking at right now. I understand that you're trying to parse it and silo it a little bit, but
I was just going by the hearing notice, the reason we're here. And I understand what you're saying. I know Medicaid recipients have suffered for years by having benefits available to them that they cannot access because providers refuse to participate in the plans. So I get that point completely. But what I'm curious about and what we're trying to resolve here is the means by which I enunciated 19 or 22 different proposals that we have before us, and some of which, Doctor, you repeated, that would go beyond the Essential Health Benefits Plan, that we are constrained from doing so because of the framework in which we have to operate. And I appreciate your testimony about the accessing of existing benefits. I am interested in this question primarily, is how you feel this existing framework will impact the future of healthcare. And although the previous panel two ago disagrees with my assessment that 2011 is a bad measure, would you agree that 2011 is a bad measure of the modern delivery of healthcare, or do you think that perhaps we should have a more modern standard?
I think this review should always be ongoing. Regardless of, as we look at this, we have to look at what should be contemplated within insurance coverage. We think we have to look at this picture broadly, which is why we brought up the other issues. But we think ultimately at the end of the day, it's about delivering the service, and when people buy a health insurance product, that it actually means something. And if it means reevaluating the services under those contracts, we think that is something that we should be continuing to look at. Now, as opposed to in terms of defining the actual mechanisms for how to do it, we certainly want to be part of those discussions. I don't think that we have a specific expertise for getting around that. We understand there's a lot of issues that have to be weighed, but we agree with your general premise that to look at it with something locked into 2011 should not necessarily be the case in 2016, 2017.
Thank you, Mr. Austin.
And if I could just
yes, please.
add there. So when you were asking one of the previous folks testifying, and you brought up the example if a new drug was on the market and it gave some benefit and all that. Since 2011, the treatment of hepatitis C has become revolutionary. It now is a curable disease. It was not in 2011. It's a major public health issue that weren't addressing in 2011 because the technology wasn't there. So it's a real example where we do have to update the benefits because technology can have profound impacts on individual patients and on the general public health.
Yeah, it's an interesting question, I think, is whether New York, through the Section 1332 waiver process, might be able to get the federal government to agree that if the state, in its wisdom, has decided that screening for hepatitis C or several of the other things that you've mentioned are necessary for proper health care, might that not be a basis for getting the federal government to say yes, and therefore you can require insurance companies to cover it? I suppose one could argue back that if the state has decided that everybody between certain ages should be tested for hepatitis C, well then thank you very much, let the state pay doctors to do that. Don't make health insurance companies pay doctors to do that. But you could also make the argument that if health insurance is supposed to keep you healthy, and if we've decided that this is part of keeping you healthy, then they should pay for it. So the 1332 waiver process could conceivably provide a mechanism for getting the federal government to approve requiring insurance companies to pay for that. And maybe a start to that process would be legislation that would add that as a mandated benefit, maybe with the proviso that that we get federal approval for it, and that might set the whole process in motion.
I certainly think, in theory, what you describe sounds like a reasonable process. I think, from our standpoint, I think we'd just like to know what else would be involved in approaching on a Section 1332 waiver, because I have to imagine that we wouldn't just go necessarily for one specific issue. We might do it at a much broader level. So, but I certainly think what you described sounds like a reasonable approach. But again, we obviously want to do a little more further understanding of what the consequences of doing that, of the broader consequence.
Okay. Yep.
Gentlemen, I thank you for your testimony. If there's anything else you'd like to supplement it with in writing, we'd be more than happy to accept it. Thank you very much to Dr. Sellers. Again, thank you for your good work. I have to tell you, I love Bassett.
Okay.
I love the system. It's an example for the whole country.
Thank you.
Yep, thank you.
Next, we call Michael Matea, President of the New York Physical Therapy Association, and Brian Lucy, the Legislative Counsel to the New York Physical Therapy Association. Hello, gentlemen. Who's going to go first?
I'll go first. Good afternoon. My name is Michael Matea. I'm a physical therapist practicing in New York State since 1980, 36 years. I sit before you and I thank you for the opportunity to testify in front of the committee. I represent the New York Physical Therapy Association, which currently is a 6,500-member organization. But today I actually sit here representing the 29,000 or so physical therapists and physical therapist assistants in New York State. And I thank you for the opportunity for us to discuss some opportunities to look at the modernization of our healthcare in New York State. When the ACA was passed in 2011, the physical therapy community at large thought that this would be an extremely unique opportunity to increase access of care to our services, and being a mandated and essential benefit in the plan. However, what we've seen over the last 5 to 6 years is that access to our care has in fact diminished through an increasing responsibility of patients for copays and an onerous utilization review process. Physical therapy and physical therapists are uniquely positioned in the healthcare. One of the main core of the ACA Act is the triple aim, and our physical therapists in New York State are probably one of the best trained, well-prepared professions to give cost-effective care and on a timely basis, which would improve outcomes. Much of the research that's been produced over the last 5 years has demonstrated that early access to physical therapy services reduces downstream costs such as unnecessary surgeries, unnecessary or more expensive testing, and in fact can reduce dependence on opioids for pain reduction. So we sit here today to discuss that with this committee. We just would like to talk to one other point, if I may. Other states have enacted legislation that has reduced or put a cap on copays, and that has not impacted or defrayed the cost toward the state in those states. So we would just like you to consider that point as we go along. Yes, sir.
That's it.
Do you have anything else? I'm Brian Lucy. I'm the Legislative Counsel. And to your point, Chairman Cahill, regarding the prior witnesses, we're concerned about the quality of essential health benefits that are delivered today. I think what we heard, which was good news, frankly, is the representatives, Department of Financial Services, it's on page 4 of our testimony, mentioned where the state has clear discretion, and it's how those essential health benefits are being delivered, without triggering the responsibility to defray costs. So that's good news. I mean, I think with the copay legislation that Mr. Matea mentioned, it was sort of questioned of whether or not that's going to trigger that requirement. And I think this hearing's useful in getting clarity on where the state has discretion. In terms of your question of whether or not today's health care is consistent with what it was in 2011,
right.
I think our perspective is it isn't. I think Michael alluded to a couple of studies about how efficacious physical therapy is, how important it is to get access to physical therapy timely for low back pain, which is a real issue in our healthcare system. There's some new information in that respect. There's the CDC just released guidelines on chronic pain and how to treat chronic pain, and that opioid therapy is not the first line of treatment, preferred treatment. So it's changing and evolving. I understand and appreciate the plan's role in adopting, current practices, but I would hazard a guess the plans are not looking at their co-payments, which are at times exceeding the reimbursement to physical therapy, and how that's keeping people from accessing physical therapy and turning patients to the quick fix of an opioid. My guess is, they're not. We have not seen the PT copays change materially, despite any evidence of the importance of the therapy services and the impact the copays have on access.
If I can speak as a practicing clinician for 31 years in private practice, what I'm seeing in the clinic in actuality is that patient copays continually increase. Many copays now actually exceed the benefit or the payment that I receive for a treatment. So we have people walking into the office where I receive $50 for a visit, the copay could be $60 or $75. So essentially what's happening in reality out in the state is that people are either not accessing the care or minimally accessing the care, which is going to and has provided a more problematic outcome for patients. So if we continue in this mode, patients won't access our care. We're going to increase our downstream costs, and the New York State citizenry will suffer greatly in the long run.
Is there legislation introduced on this point?
Yeah, it's Assembly 1063A.
1063?
Yeah.
Hey,
Okay, thank you.
no.
Yeah, I've always sort of thought that health insurance companies' notion is that if something is going to really hurt or remove part of your body, they're perfectly happy to pay for that on the assumption that you're not going to want to do that, and therefore they don't have to really worry about utilization. But if something really is not painful or obnoxious or deprives you of part of your body, that they don't want to pay for. And I think this falls right in line with that theoretical construct.
One of the quandaries for us is that our approach to health care is at many times multiple visits, and it requires patients to attend, to be proactive in their health, which in the long term helps them across the age spectrum. However, when you look at a $50 copay twice a week, you're looking at $400 a month, and in today's economy, most of New York State residents don't have $400 a month to spend.
Yeah.
So I can tell you that in my practice, I've actually taken to, FaceTime with people because they just don't come in for their exercises, and now I'm responsible to help them through the episode. And that's, so we're seeing that type of not accessing the care. And I do think that, as Brian has said, the legislature has some ability to look at this.
Yeah, I would just add physical therapy is not easy. It requires patient commitment. It requires time. It's certainly a lot easier to get a prescription, to go to imaging, to get an injection. If you look at low back pain, I'm sure the Excel's put out a study. There's very low utilization of physical therapy in upstate for physical therapy. I'd hazard a guess that part of that's due to the cost of the co-payment.
Just to piggyback on the prior from Misny, you know, my colleagues who are orthopedists are becoming growingly concerned about the outcomes of their surgical patients who, you know, have a shoulder repair or a knee replacement and then have a hard time accessing the end care that they need to finally put them back on their feet. And it's a growing concern amongst the community of providers. So I think the copay issue and accessing it is something that crosses many providers right now. The other issue for us is the increasingly onerous utilization review process. So most of your managed care or essential health plans will require that a physical therapist submit a plan of care and in some cases actually have some voice in how many visits are approved for the patient. In many cases, we're seeing, you know, it's a computerized system where we simply put in a diagnostic code and a functional scale that the patient is responsible for filling out, and then we receive back, irregardless if my opinion is 8 visits, we get back 6 visits. And then what will happen is, you know, if we need to go past those 6 visits, then we have to go through the process again. And at that point, again, we're not asked, you know, what our recommendations are. We're pretty much told. And at that point, there's also at times a large time lapse. So now a patient will be with us for 2 or 3 weeks, be making progress, and then we submit for, let's say, a recommendation of 4 more sessions, and we wait 10 days to 2 weeks to hear about that. And some of the benefit that we've accomplished over the course of the first 3 weeks is lost to patients who don't access the care at that point. So, you know, it's a multifold issue, more in terms of limiting the access of care, and that has definitely become more of a problem in the last 5 years.
Okay. Gentlemen, you were present, I believe, earlier when the first panel was testifying, Ms. Frescatore, Mr. Oshner, about that which is and is not included in the essential health benefits cap. And one of the things that is not included, that is excluded specifically, is co-insurance charges and co-payment charges. That's strictly a state determination. It's strictly in many instances, an insurance company by insurance company determination. I don't believe we set a minimum standard for that in statute. You also heard them testify that the Oxford plan that was adopted in 2011 is being readopted for 2017, and that the only change was that the number of physical therapy visits that was permitted in 2011 has been increased going forward. Are you familiar with what that benefit is, and is it an adequate benefit as a basic benefit to offer insureds across the state of New York?
I can't speak directly to the direct benefit because, quite honestly, there are so many plans that
I'm talking specifically about our benchmark plan.
I do understand. I don't know what the benefit. I think I was not here for that first testimony.
Okay.
I would just say it's an improvement. I think, you know, when you have lifetime limitations and you have people with chronic conditions, you know, they certainly could exhaust. I think before it was 60. Right. You know, so that's an important change, and I think that's going to be helpful to the public in terms of accessing care. We did, you know, when they first adopted the benchmark plan, we sat down with representatives of the Department of Financial Services. We weren't afforded that opportunity this time around.
Just so happens we got a better deal.
Yeah. Well, yeah, that's true. It's great. You know, but you know, even, you know, the co-payments, you know, under the plans, you know, as I understand it right now, are $25 and $35 for physical therapy.
Well, again, all due respect,
Okay.
I'm trying to stick to the topic of the hearing as much as possible. And by the way, I fully appreciate your testimony of the previous panel with regard to some of the other complications involved in accessing insurance benefits. And I also recognize that a benefit is meaningless if somebody can't use it. And if they can't use it because there's providers that won't provide the service, if they can't use it because the co-insurance or co-payment charges are exorbitant and unaffordable, it's not really a benefit. I get that part. But in terms of the essential benefit, if you would be kind enough to take a look at the benefit that was offered in 2011 that's part of our current essential benefits plan, and that which will be offered starting on January 1st of 2017, offer your comments on that enhancement of benefits.
Absolutely.
I would very much appreciate that.
And we appreciate
That's
the
something I can count on you to do?
Sure. Absolutely.
Well, I appreciate that. Is there anything else, Mr. McDonald? Is there anything else you wanted to add before we send you on your way?
No, I'm thanking the committee for having us here to share our thoughts and testify in front of you. Thank you.
Thank you very much.
Thank you.
Thanks. We have one late addition to our panel. Her name is Kathy LaFond Evans. Are you here? Kathy LaFond Evans? I'll say it 3 times because that's what we do. Kathy LaFond Evans, on behalf of the Mito Hope and Help, affiliated with the Warren and Washington and Albany County ARC. Well, I guess Ms. Evans couldn't hang around, LaFond Evans couldn't hang around, but that's possibly because we weren't certain that she would be able to testify. So that does conclude the witnesses who wish to testify. I would urge anybody who is within the sound of my voice, including those present in the room, that if you have anything you wish to submit in writing, we are very appreciative of written testimony as well. If there's nothing further on the part of any of the panelists here,
Nope.
I would then hereby adjourn this hearing and thank you all very much for your participation and attention. Thank you.